This has historically been one of the most difficult steps to learn for the novice cataract surgeon. Once a rhexis has gone radial, instructors have been reluctant to allow resident trainees to attempt the rhexis rescue, as it is a high-stakes, one-attempt maneuver. A recent article by Marquez and colleagues highlights the fact that the unrescued anterior capsule radial has, even in experienced hands, a 50% chance of later extending to involve the posterior capsule. Little and colleagues recently published a safe and effective technique for rescuing anterior capsule radials. Unfortunately, until recently, there is no good way to practice critical rhexis rescue techniques. The IC Virtual Reality Surgical Simulator allows the cataract surgeon to simulate capsular rhexis techniques using a three-dimensional physics-based model. By using the simulator's standard capsular rhexis modules in a non-standard manner, we created a curriculum where the instructor intentionally radializes rhexises to simulate a lost anterior rhexis and then allows the trainee to practice the little rhexis rescue technique to competency. Here is a demonstration of the little rhexis rescue technique as recorded on the IC Surgical Simulator. With a radializing rhexis, the resident is instructed to first unfold the capsular rhexis flap. Next, grab the flap as close to the edge of the extension as possible, then pull in a backwards direction opposite the direction that the rhexis has been radializing. While maintaining the backwards pull, the pull direction is then directed centrally, and the rhexis turns on a dime. Even though the IC designers were not aware of the little rhexis rescue technique when they designed the capsular rhexis module for the surgical simulator, the physics-based model allows for a very realistic and appropriate simulation of the little rhexis rescue technique. In this video, the instructor intentionally loses and then performs the little rhexis rescue technique twice, and then finally loses the rhexis to demonstrate that the physics modeling is such that losing the rhexis is possible with inappropriate rhexis technique. Although the instructor in this simulation video safely performs the little rhexis rescue technique twice, we now have a platform by which resident trainees can practice what used to be a very high-stakes activity without negative sequelae for patients. Finally, the instructor demonstrates that inappropriate technique can lead to simulated loss of the anterior rhexis. After viewing our instructional curriculum and videos, residents then have the opportunity to practice the capsular rhexis rescue techniques on their own. In this video, the trainee uses a cystotome to initiate the capsular rhexis flap. At any time during the procedure, the surgeon may switch between a cystotome and a capsular rhexis forceps. After an initial needling of the capsular rhexis flap and switching to the capsular rhexis forceps, the surgeon unintentionally leaves the capsular rhexis flap too radial. During this initial training attempt, the resident elects not to perform the little rhexis rescue technique. Instead, the resident chooses to use the virtual cystotome to create a nick in the anterior capsule and restart the capsular flap in the other direction. Because of the physics-based modeling incorporated into the simulator, the resident is able to experience the sequela of this suboptimal technique. Specifically, although the resident is able to create a continuous flap going in the opposite direction, because the initial radial is so peripheral, he is not able to connect the flap to the initial flap, and hence an anterior capsular radial remains at the end of the procedure. Contrast this to a subsequent surgeon who, in a similar situation, chooses to perform the little Rexus rescue technique which they were recently trained in using the virtual reality simulation. For the sake of clarity, we are showing the video unedited in real time. Note the safe creation of an initial flap using the virtual cystotome. After the surgeon grabs the capsular rexus flap with the virtual forceps, it is clear the rexus is going to go radial. After choosing to perform the little rexus rescue technique, the trainee surgeon effectively first unfolds the capsular rexus flap, second pulls backwards on the flap opposite the direction that the capsular rexus was going radial, and finally directs the forces centrally, resulting in an effective acute turn and rescue of the peripheral going anterior rexus. To summarize, to our knowledge, this is the first time an intraocular capsular rexus complication can be virtually simulated and the correct remedy trained for and rehearsed. We have now incorporated this virtual reality training of the little rexus rescue technique into our residency program. We wish to thank Dr. Little and colleagues for their outstanding contribution to resident training.